We're ready to start. Good morning, ladies and gentlemen. Certainly welcome back. Happy to have you here at the 41st Annual Cancer Control Society Convention, Labor Day weekend 2013, here at the Sheraton Universal Hotel in Universal City, California. The next presentation is actually about the protocols of Dr. James Forsyth in Reno, Nevada. Some of you have seen him here in the past. Some of you are familiar with him through Suzanne Summers' work. He had an emergency and couldn't make it. He wanted to know that, all of you to know that he loves the Cancer Control Society as we love him, and is very sorry that he couldn't be here. However, I think that we will be well served with Dr. Winter, who is practicing with Dr. Forsyth. Dr. Winter earned his DO degree in 2000, completed osteopathic rotating internship, specialty training in 2004, and he also worked with Dr. Frank Schallenberger, who's also been here, another one of our good friends, and he left his post medical director, Reno Sparks Indian Colony Tribal Health Center, to work with Dr. Forsyth. And in his second year of an integrative oncology fellowship, Dr. Winter, very happy to have you here.
Thank you.
Thank you.
Hi, everybody. The man, whoa, sorry about that. Is that a bit much? Okay. Sorry. Right. So the man on the book is not the man at the podium. What happened? Dr. Forsyth is board certified in oncology. In fact, did you know he was in the first class of oncology subspecialists that there ever were? He's also board certified in internal medicine and certified in homeopathy, and this is his outcome-based investigation. Well, why isn't he here? This is the heart of a saint, and that arrow is where the stent was placed. That's how it should look. This is how it did look. Look at this. You see this little sub-millimeter line that is responsible for getting all the blood from the mid-portion of the left anterior descending artery down to the rest of his heart? Dr. Forsyth was veritably on the razor's edge of life. And then, thankfully, he caught it, he fixed it, he's fine, but he couldn't be here, I'm here, he's at home recuperating. So, here I am, outcome-based investigation, 500 patients. Oh, by the way, how do I get this timer started? For the sake of the crowd who's tired and things. Wow, thank you, whoever did that. Okay, 500 patient study. We're at our 40th month. These patients were taken from June of 2010 to this month. What we're studying is, how well do we do if we do chemosensitivity testing and insulin-potentiated chemotherapy light? And I'm presenting this. My name is Dr. Winter, DO, HMD, Integrative Oncology Associate. Here's our disclaimer page. We don't really have anything to claim. We need to discuss the off-label uses of chemotherapy. Well, as we're going to establish, it doesn't really work that well, and so, yeah, we're off-label. We go lower doses, and we use the agents that actually work instead of the ones that are in the guidelines. All the cartoons came from naturalnews.com. All right. So there's three main components to the talk today. One, what's the problem? Two, what are we doing about it? And three, how well does it work? So here we go. What's the problem? Here's the cartoon that illustrates the problem. We're ramping up against Syria right now, and so I thought it'd be apropos to get the kind of military-type cartoon up. The gentleman over here says, that's nothing. We've got a chemical weapon that can destroy the heart, liver, brain, and anything in any human being. And this guy's holding up a bullet over here. This guy goes, it's chemotherapy. He's got a syringe. Man, I have practiced this study like a million times, and I still think that's funny. But anyway, what are we talking about? Why is chemotherapy so harsh? Well, for one, by its nature, it's designed to be harsh. We're trying to kill tumors. But the second thing is illustrated in this slide right here. This is This is illustrative of what happens if you've got cancer and you show up to any conventional oncology office. It doesn't matter if you're somewhere with a high reputation or in a very rural country. The oncologist will reach up, pull down the Betty Crocker cookbook of oncology medicine, open it up to the chapter on, let's say, colorectal cancer, and it'll say, okay, well, if they haven't had anything first, give folinic acid, 5-FU, and oxaliplatin, and maybe some Avastin. It doesn't matter where you are, they're all reading from that same manual. They're going to give the same dose to the same patient, but in the final analysis, it's a guess. But we're guessing with a toxin. If you give a patient a poison and it's not actually effective against the cancer, guess what? All you're doing is ruining their immune system and leaving them off worse than when they started. But we promised non nocere. We said we weren't going to hurt anybody. So we need to rethink how this is working. How is this working? This slide is the abstract page of a meta-analysis that was done on a humongous population, both in Australia and then also in America, showing that the overall contribution of oncology, of medicine, of oncologic medicines, to the 5-year survival rate in stage 4 cancers was a paltry 2 to 2.3%. That's the problem. Ha! We've succeeded. We have now discussed the first part of the talk, which is, what's the problem? The problem is chemotherapy is so doggone destructive, it's not only killing the cancer, maybe, but it's definitely hurting the patients. What do we do about it? We cross from the dark side of the force over to the light side? I don't know. I love this cartoon too. Look at this guy over here, this crook running down the street with a... Oh, man. Okay, I'm sorry. So anyway, we join forces with the good guys. That's what we're doing. Step number 1 in the Forsyth method that he's teaching me is empower the patient. It's just like the previous speaker said. Look how much you can do. You're so intelligent. You have so much reserves. You can be so scrappy. The patient can very frequently, with the right information, get themselves into at least a remission, if not a complete remission. So at Forsyth, we recognize the power of the patient, and we respect the power of the patient to decide how we go forth in their treatment. Patient comes first. Dr. Forsyth's second issue that makes him unique would be this quote here: quality of life. If we can improve the quality of life in a patient suffering with this malady, that is associated with response rate, right here. And so you can, okay, so what is stable disease? If the cancer isn't actually getting worse, that's considered stable disease. And then, of course, there's partial remission, which is more than 50%, and then complete remission, where it's completely gone. Even stable disease can be tolerated and metamorphosed into a chronic, livable condition. You can manage your cancer. But this comes to a third issue. We need to avoid setbacks in our road to health when we suffer with cancer. Those setbacks are represented by many of the side effects associated with chemotherapy. Down here at the bottom, this study shows that the cure or kill approach to advanced cancer treatment is not the only answer. What else do? We learn, we count, we trust, but we verify. At the Century Wellness Clinic, all we do all day, every day is treat cancer. We treat so many patients with cancer that we're able to count them and get to statistical significance in our studies. One of the things that Dr. Forsyth is training me to do is to do studies, to count. Go ahead and be brave. Look, in 2002, he did a study on pawpaw. 2004 to 2006, he did one on Poly MVA. Now he's doing one on basically immune boosters plus chemosensitivity guided IPT. This is the state of his art. This is the state of our art. No, it's not. This is Poly MVA. What is Poly MVA? You can read the slide. Oh, and by the way, I have handouts prepared. I have 100 of them. When we get through and you guys go on break and you walk out the door, there'll be 2 staff members with piles of this lecture, and you can have all the slides. Woohoo! Oh, Special thanks to Al Sanchez with Poly MVA who helped me do that. Basically, Poly MVA is an alpha-lipoic acid palladium dimer that is able to be drawn towards cells that have low voltage. Cancer cells produce low voltage. The Poly MVA goes inside, it upregulates mitochondrial function, gives the cancer cell enough energy to either differentiate into something healthy or complete its apoptosis pathway, meaning its programmed self-destruction pathway. Poly MVA is also very good for immune cells. I did not know this. There's 60 trillion cells in the human body. 1/3 of them belong to the immune system in some way or another. Poly MVA is able to find the immune cells that are not functioning very well and then upregulate their ATP production and help the immune system fight well. This is a little bit more about Dr. Forsyth's study on Poly MVA. It was a 6-year overall survival. It showed a 6-year overall survival rate of 1/3 on Poly MVA or Poly MVA plus chemotherapy. Astounding compared to what conventional therapy can do. Another thing that Dr. Forsyth is showing me, there's nobody else, is to take away the triggers. If you've got a roaring line of cancer, sometimes all you got to do is take the thorn out of its paw and it'll settle down for you. Take out the heavy toxins. Take away the allergies. Treat the underlying fungal and viral etiologies. The cancer will settle down in some cases. This is the state of our practice. We're going to take it day by day. That's what we do when we have cancer. On Mondays, we give Poly MVA, which is over here on the right. We've already talked about that. And Forsyth Immune Protocol. What is Forsyth Immune Protocol? This is Forsyth Immune Protocol. It's a proprietary blend, but essentially it's a Myers cocktail with DMSO. I think that's what our last two speakers were talking on. All right, so we got through Monday. This consists of 2 hours in the lazy boy chair with an IV hooked up to you, and then you're out and about afterward. Also, I should say, on Mondays, Wednesdays, and Fridays, we're enhancing the immune system's function. At Century Wellness, we recognize it's the immune system, silly. It's the immune system that has been holding us all of us, look around. All of us has 4, maybe 5 different kinds of cancers in us right now. They're not circulating, they're at the cellular level. Why don't we actually manifest a tumor? Well, because our immune system is able to identify and destroy it. No sooner does that happen, a new cellular aberrancy arises. And then our immune system goes and finds that. The immune system is tantamount. We have to treat the immune system. Good. Sorry, I got a little passionate there. Tuesdays. On Tuesdays, we use Forsyth Immune or IPT Light plus glutathione. What does IPT stand for and why on earth would we use it? Insulin potentiated chemotherapy. What? Chemotherapy? Oh no. Well, yeah, if you have to, though, you have to. Like the previous speaker said, try to handle your cancer without having to go to these toxins. But our clinic, our niche, is where there's no other way. I mean, you have to lower the tumor burden. Turns out these doggone cancers will actually turn off your immune system. So there is a place in some instances where you just have to use the cytotoxic agents. How do we do that intelligently? Let's see. Number 1, test them. Find out which ones will actually work, for crying out loud. Here's which ones Dr. Forsyth is using. These are chemosensitivity testing. I'm going to go in broad brushstrokes because I've only got like 13 minutes left. Essentially, what we're trying to do here is get a piece of cancer, clone it, and then take every chemotherapy off the shelf and try it on your cancer to find out which one will actually work. Same with the nutritional supplements. We found a test that will take all the nutritional supplements off of the shelf and find out which one works on the patient's custom cancer. Not all cancers are created equal, just like all of us have different DNA strands, different genomes. Harvested from blood, just a popliteal fossa, simple blood draw, and then off to Greece or Korea or Germany, and then they clone it and test it out. This is Dr. Forsyth's big point, a blueprint. We need a blueprint to build health in the cancer patient, and this chemosensitivity testing provides that. In America, we're still behind the curve a little bit. What we see here is mostly tumor or tissue samples, which are a little anemic in the number of genes tested and the number of chemotherapy, and they actually, I haven't seen one that will actually show us which natural substances will work. Plus, when you're doing what we're using, these circulating tumor cells, the circulating tumor cells, what does that represent? You've got something big enough to actually be breaking off and getting into the bloodstream and circulating around looking for a new home in the brain and the liver and the lung and the bone, something like that. Those are the bad actors. Not all parts of the tumor are equally evil. Some parts are perfectly benign. It's the metastatic parts that we got to focus in on and kill and stop. We like the circulating tumor cell test for that. This slide is about the good gene test. They're from Korea. It's an extremely good test. This is the way that the test results are given. It's nice because it prescribes for the practitioner exactly how much of what to give. It's not nice because Dr. Forsyth, with his 40 years of oncology experience, has a better way to do it and can tweak this. Now, look up here at the top. You see this RGCC thing? That means this one's from Greece. This is Dr. Forsyth's favorite right now. Why? Look how robust. Look at all the genes it tests. All of these can either cause cancer or not let it, anyway, not let the cancer take off. If any of them are messed up, then you can get cancer and your cancer will get worse. Look at this, 40 agents. Look at all these supplements. Not all of them work for everybody. Which ones work? Well, this test will tell us. Now, if you're not going to give your patient this test, this is what our experience is showing very frequently comes up. This one, artemisia. Oh, I love it. That's my favorite one right there. Anyway, I can't nerd out on that. Point is, these are the ones that typically are coming up positive for being effective. If you can't use a chemosensitivity test, these ones are really good. Look at this. These blessed Greeks. I know their economy stinks, but man, have they ever come up with a good test. Woo, loving it. Look at this. Okay, so indole-3-carbinol and curcumin. Well, what happens if you have to choose one or the other? You can see, look, it's so obvious. This one has a 40% kill rate. This one has a 15% kill rate. Go with curcumin in this case. It takes the guesswork out. I love it. And I really love it with this slide. Look at this. Holy tololi. Okay, remember when we were talking about colon cancer and how on the Betty Crocker cookbook it says you got to use oxaliplatin? Yeah, but it's only 40% effective. What about, look at this one, ifosfamide. Or how about Cytoxan or Cyclo? Look at these guys. These guys are way better. Let's use these ones. Why do we have to do it the cookbook way? Why can't we do custom care? Okay, so we look before we leap at the Century Wellness Clinic. We don't just throw some poison at you and hope for the best. No, find out what works. Next, we got to leverage cancer cell physiology in order to produce good results. I'm going to have to let you read the rest of the slide, but you see this part up here about simple sugars? These cancer cells are obligate sugar fermenters. They can only metabolize sugar. So what we're going to do is we're not going to give full dose, well, it's America. If the patient really wants full dose chemotherapy, well then fine, but it's kind of like going to the steakhouse and ordering vegetarian. But anyway, yeah, what we recommend is natural plus IPT light. We bring the blood sugar down low, starve the cancer cells of sugar, they open up their pores, they get very, very aggressive toward taking in sugar molecules. Then we bathe the tissues with chemotherapy, 10% of the normal dose, ask the patient to drink some organic orange juice, purposefully change these cells, these cancer cells, because of that sugar spike. It's going to make them grow and get vulnerable. At the same time, they're sucking in the sugar, they suck in the chemotherapy, boom, you just made a smart bomb out of the cytotoxic agents. You just got that really harsh chemotherapy, 10% dose, right where it needed to go, right when it was vulnerable. Beautiful. Here are our IPT orders. The main point on this slide is just right here. 2 agents. That's it. That's all we need. You start with the two most effective, with the lowest side effect profile, and you see what you get. And typically it's fine. You don't have to get 5, 7 different agents all at once. No. Plus, if you get a side effect, what are you going to do? And you have no idea which one it was. It's a mess. Forsyth's way, I really like it. 2 agents, 2 at a time. How's it feel? Man, we've got 40 of these lazy boy infusion chairs in our clinic. They're usually full. Nobody's throwing up. Nobody lost their hair. Nobody's running to the bathroom to have diarrhea or retching. We don't have the paresthesias. I mean, look at this side effect profile. This is fantastic. So it's very, very well tolerated. Remember, quality of life is key at Century Wellness. Okay, so that's Tuesday. Except we haven't talked about glutathione. Previous speaker did. Man, it was fantastic. Great speech. What happens to the residual chemotherapy that didn't obediently go to the cancer? Well, it stays there and hurts you. Not at Century Wellness. We use glutathione. We infuse it in the vein, and like the previous speaker said, it's an antioxidant. It goes to the cells that are oxidizing. Are cancer cells oxidizing? No, they're anaerobic. They don't use oxygen. The glutathione goes to the healthy cells, scrubs off the cell membranes, and that's a way to ameliorate the residual toxic effects of the already low 10% chemotherapy that we use. We potentiate it with insulin. That's another important part. On Wednesdays, we use vitamin C and hydrogen peroxide. Because of time, I'm hoping that previous speakers have already touched on the mechanism here. Suffice it to say that both of them not only improve the immune system, but also are deleterious to cancers. They're oncocytic. Thursdays are like Thursdays are like Tuesdays, Fridays are like Mondays. And then what? We send the patients home on maintenance, low-dose oral chemotherapy or a targeted agent, depending on what their Greek test showed. And then we ask them to return in 3 months for a follow-up. Is that it, though? No, I say. Actually, we follow the patients very closely. Most of our patients are from out of state or out of country, and we adhere to a very strict policy of close telephone contact. We order serial imaging studies to see if the tumor is continuing to go into remission. MRIs, look at this. Ultrasounds and MRIs are best. X-rays are okay, they're the lesser of the evils. And of course, physical exam is brilliant. That's the best if you can. PET scans, CT scans, bone scans, those are our least favorite. Look at this note down here. He discourages excessive use of CT and PET scan. Here's a funny cartoon that illustrates the point. Which one do I use? The one that detects cancer or the one that causes it? Oh, we use both. That's funny. Try to make the point quickly. Here, it makes the point, but it's just a cartoon. It's really the PET CTs of the abdomen and pelvis. There's your 30 millisieverts of ionizing radiation. That is really going to be harmful to these sensitive immune cells that we have. On a mammogram, it's not really the ionizing radiation. It's that, but why you gotta traumatize and radiate tissue that's already proven a propensity toward oncogenesis? Why can't you do a thermogram or an ultrasound or a breast MRI instead? But anyway, the bigger of the evil is the CTs of the abdomen. Caveat, this is in the context of our practice. We're following cancer patients. We want to see if they're getting better. Conventional guys will get a CT scan every 3 months. That's way too much ionizing radiation. Now, what happens to our cancer patient who gets in a car wreck in the ER? Now the surgeon needs a CT scan to determine whether to cut or not. We're not talking about risk of dying from ionizing radiation. We're talking about risk of dying right now in the ER. Get the ionizing radiation if in a trauma situation or an emergency. But for surveillance purposes, like in our practice, it's not really necessary. Another way is cancer tumor markers. Here is Dr. Forsyth's Hall of Fame. Look at I don't know if you can appreciate this, but for me it's a big deal. Here's a 73-year-old with esophageal cancer, with metastases to the lung, still alive 3 years and 4 months later. I mean, this is fantastic. I can't go into all these stories, but they're impressive. Look at them all. Anyway, sorry. Anecdotes are great, but, show me the proof. Here are the goals of the study: to show that it's better than conventional, to show that chemosensitivity testing can give a blueprint for how to build health in a cancer patient, to show that you don't have to do full-on IPT on these poor, fragile cancer patients. You can just do IPT light the way Dr. Forsythe does. I'm sorry, guys, you're going to have to read the handout. I have to go. Patients want to know, okay, so how well do you do? We're unique because we have the numbers to actually show them. They want to know what parameters we're using. These are the parameters. Parameters like, okay, so were they male or female? What's their initials? What kind of, when was the pathologic diagnosis made? What kind of cancer do they have? These are all parts of his cancer study. Did they use Poly MVA? Did they use the chemosensitivity test? Are they alive or have they expired? Are they, in stable disease or are they progressing? Okay, survival column requirements. This is important. If the patient comes to us but then passes away within a month, that doesn't count. We didn't get enough chance to work with them. If the patient had breast cancer but got hit by a bus, that counts as a death in our study. Right? So it's all-cause mortality in our study, not just cancer deaths. And you got to use measurable parameters. If we're saying that they're in stable disease, it's not because they had the strength to walk into the clinic. It's because the tumor markers are showing that they're okay, or they're imaging studies. So it's a real study. Here's how we're doing. I have to move on. This is a breakdown of all the different patients that we've had, all the different kinds of cancers. Here's the total number of patients, and here's the percent surviving at 3 years and 4 months. This is what we're comparing ourselves against. This, after 5 years, 2% contribution to survival. We can compare ourselves to national average at 2 years. Look, but watch this, because this is stage 4 at 2 years. National average just above 40%. Competitor around 63%, and here we are at 85%. This is another one, good one. This is showing cancer patients that are like the ones who are coming to our clinic because they're stage 4 and they're chemo resistant. A lot of our patients have been told to go home and die, and then they come to our clinic and we work on them from there. At 3 years and 4 months, our overall survival rate is 60%. Compare that to a few slides back where, chemo-resistant survival rate, 18 months top. Here we are at 40 months. Most of them are still alive. This would be a sum-up slide, but we've already made the points. Here's Dr. Forsythe's books. Go visit the bookstore outside. And please feel free to pick up a copy of the lecture on your way out. It's been a pleasure.